Okay, so my name is Stacy Farr. I'm our co-director of the Healthcare Institute for Innovations in Quality. I'm really excited for this session today on the changing federal landscape, the future of regional healthcare. So first, I just wanted to share, this is our schedule of the IQ forums that we have going on throughout the year. And as you all know, today is March 26th. Good job. And so we're currently on Changing Federal Landscape, What is the Future of Regional Healthcare? So that's today, and you can see the rest of the forums for the year here. And today's session is, really exploring the One Big Beautiful Bill Act, OBBBA, which was signed into law on July 4th of 2025. And I won't read that middle paragraph, but then, this IQ forum, what we're going to do is really start to think through and unpack a lot of the healthcare and healthcare workforce challenges and how that plays out here regionally in Kansas and Missouri. So I just wanted to set the stage and lay out, at least at the highest level, these are also from the Kaiser Family Foundation, but just lay out the high level provisions across the different categories to kind of set the stage. I'm sure some of our speakers will go into certain aspects of these a lot further, but I just wanted to lay them out at a high level so we all had some of these kind of in our, back pocket. But as we know, one of the provisions or some of the categories are specific to Medicaid. And so particularly within eligibility and cost sharing, section 71119 on the work requirements, we know that what used to exist prior to the passage of the budget reconciliation law was that Medicaid eligibility could not be conditioned upon meeting a work or reporting requirement without getting a section 115 waiver. And during the previous Trump administration, 13 states did obtain that. During the Biden administration, most of those were rescinded. During the new administration, there'd been interest. And so now what we have is through this bill is that states are now required to condition Medicaid eligibility upon basically, through working or showing eligible activities that are essentially work for 80 hours a week or 80 hours a month. And I share just the CBO, Congressional Budget Office estimates of each of these impacts, both on dollars as well as the uninsured, because that has a trade-off as well. So they estimate this will reduce federal Medicaid spending by $326 billion over 10 years and increase uninsured by 5.3 million by 2034. The Affordable Care Act is kind of the next category of healthcare provisions within OBBBA, and this in section 71303, pre-enrollment eligibility verification for premium tax credits. What we used to have is that new enrollees upon, they were granted a conditional eligibility. If there was like a mismatch of information they had submitted, they had up to 90 days to do the verification. And also nearly half of the marketplace enrollees were also enrolled in an automatic renewal each year. And now there will be a verification of income, coverage status, place of residence, family size status as alien before coverage, et cetera, as well as a removal of the automatic renewals. And the CBO estimates this will decrease budgetary spending by $36.9 billion and increase revenue by $4.4 billion through 2034, as well as increase the uninsured by 700,000 people in 2034. Then in terms of the Medicare provisions, there's 71201, limiting Medicare coverage is about, oops, I think I turned the page too fast. Was what we had previously prior to the law was that U.S. residents were eligible for premium-free Medicare Part A if they or their spouses were working. And now what we have is that Medicare eligibility for you is restricted to these categories. So basically what it takes off is the people who are in temporary protected status, refugees and asylees. And it also terminates Medicare coverage no later than 18 months from enactment for anyone who is, currently covered, but then no longer eligible under these changes. And the CBO estimates this being a reduction in spending by $5.1 billion over 10 years, increase uninsured by 100,000. The next category I was going to cover is the health savings accounts. And I actually am there are two more sections I'm not covering here, but one of the sections that is being changed is Section 71306, permanent extension of the safe harbor for absence of deductible for telehealth. And so what this was really during COVID, federal law permitted the HSA eligible high deductible health plans to cover telehealth before deductibles until the end of 2024. That was expiring, and so now it's permanently allowing high deductible health plans with HSAs, the typo state, to cover telehealth. I don't know why we don't have it doesn't understand HSAs yet and automatic, come on. And then the CBO estimates this will decrease revenue of $4.3 billion through 2034. There are two other provisions within the OBBBA that also touch upon the health savings accounts that I don't have up here on the slide. These were the treatment of the bronze and catastrophic plans that are now going to be a part of that can be paired with an HSA through the high deductible plans, as well as the treatment of the direct primary care arrangements. So that's just a little bit of high level. There's actually a really great implementation map. If anyone's so interested, it's on the Kaiser Family Foundation website. This is one screenshot of 7, but it lays out the whole timeline by category of health and what is getting implemented when. So if you're really interested, it's a great resource. They're always such a great resource for understanding policy. So I wanted to share that and then say, why does this conversation matter now? We clearly know we're under a changing federal landscape with these new federal cost containment strategies. And in particular, when we think high level, I kind of broke it down by some of those key categories, but at high level, the CBO did state, an anticipated reduction in federal spending of healthcare by $1 trillion, but also then leading to, changes in coverage, reimbursement, and workforce with 10 million people uninsured. So we all know that has its own cost and long-term implications that we'll examine today, I'm sure. We also know there's a growing emphasis on accountability and value. And how does this affect our region? We know that all, the effects of these policies are going to differ across different state systems and CBOs. Rural health is obviously a big deal here in our region. We do know that there's the Rural Health Transformation Fund that also exists out of this plan. It's a $50 billion investment over 5 years, but it's not really expected to offset the Medicaid cuts, which are, we're expected to see a 21% decline in the Medicaid reimbursement due to these provisions as well. So even though there's a large investment, it's not really expected to even weigh off what it's cutting. And so we obviously need to, things like this, we need to be here today and learn and share with each other so we can come together and have a shared understanding and kind of create the opportunity environment so that we can realign resources and partnerships so that we can, continue to care for Kansans and Missourians under these big changes. So before I turn it to everyone else, this is our great lineup of speakers that we have today. Going to be a really great session. Happy to be here. And just wanted to share, do also mark your calendars for our next IQ forum is May 21st, which will be New Directions in Senior Care. And we have really great speakers coming together for that one. And we also want to take a moment just to, share gratitude for all of our sponsors of the Healthcare Institute for Innovations in Quality, the Frontiers Clinical and Translational Science Institute, Health Forward Foundation, BioNexus KC, UMKC, who are all great partners to us. So with that, thank you. And I will stop sharing and then I will turn it to our first speaker is joining us online. It's Josh Moore. And Josh is PharmD, Director of Mo Health Net Division, talking about a pharmacological perspective on emerging trends in Medicaid prescription drug pricing negotiations. And then everyone else is in the room. So just for people like to know that's things. But the floor is yours, Josh.
Sorry, I'm trying to figure out the sharing. I thought I had it figured out, but I am now back in. Can you see my screen?
Yeah, now we see it. It's perfect.
Awesome. So yeah, I'm Josh Moore. I'm the new Medicaid
Apparently
director.
It's not perfect. One pause.
Nope. Wait, I gotta move you out of the way. How about that?
Thank you.
Do what?
Josh, there's something on Josh. He took care of it. There were a split screen where there were too many images on the screen. Josh,
Oh.
good.
but now we don't
All
see
right.
his face.
We're all good. Okay, perfect. Yeah, so
But
I'm Josh Moore, Medicaid
share your
Director
video
for
again, please.
What do I need to do?
Share your video so we can feel the dynamic presence of your video.
Oh, so apparently I think this stops the video when I'm sharing
Okay,
content,
no
but I
worries,
will
no worries.
try. We're gonna do two things at
There, see
once.
you again.
How's this going? Okay, and then I'll
That's
move you off the
perfect.
screen.
And it's not anymore, but that's good. Go ahead.
All right, we tried. Six times the charm. Yeah. So going to talk a little bit about the new federal innovations in the Medicaid drug pricing, Missouri's perspective on that, on how we're navigating the CMMI models to improve access and sustainability. You're probably asking why the Medicaid director is focusing so much on the pharmacy perspective. And that's because 3.5 months ago, I was the pharmacy director for MoHealthNet. So that's what I was really engaged in and became somewhat of an expert in I was that position for a little over 6 years. So we'll skip past the disclosure that I put on all these, and then we'll go right into the shift towards the greater federal involvement in pharmaceutical pricing and outcomes. You've probably seen this a little bit more on TV. And these are some of the models in CMMI. So CMMI has put out a number of pharmacy models after not putting out very many at all for the last number of years. They put out 3 in the last 2. So they create these new innovative payment models to try and address rising costs and quality. And they can be under Medicare, Medicaid, and CHIP. I'm going to focus mostly on the Medicaid pieces of these, but there is a little bit of overlap into Medicare, specifically on the balance model. So those 3 models that I'm going to talk about today are the generous model. And most people have heard of this as the most favored nation pricing. And then the balance model, which is around the GLP-1s. And then the cell and gene therapy model is the most mature, but most mature is very young. It's just over 1 year at this point that we've been in that cell and gene therapy model. So most favored nation is an easy thing to conceptualize. It's a little bit more difficult when you have to put this down in writing. So the concept is really that the Medicaid program would pay no more than the lowest net price received by comparable developed countries. That's the G7 plus Denmark and Switzerland. And it's actually the second lowest, and it's GDP adjusted. So it's not a simple one-to-one where you would be able to go to whichever country, look at the price and say, that's exactly how much we'll pay in Medicaid after all the rebates. There are adjustments that will occur. It's again, like anything in healthcare, it really comes to a lot more complexity than that as we try to make sure that this is fair. Bit of market momentum here. 16 of the top 17 manufacturers actually joined the generous model on the manufacturer side, which means it could be pretty impactful to the Medicaid program in terms of sustainability of the drug program. How this is going to work, it's in theory. So it says it's a 5-year pilot from January 1 of 2026 through December 31st of 2030. So you're probably thinking, wow, it is past January 1st, 2026. And you would be correct. Some of these offers are actually going to be retroactive offers. And so, of course, retroactive negotiations are always really interesting. So we're working with CMS to try and figure out exactly how this would apply retroactively to criteria that we've already established, we've already paid claims for. The theory would be that national offers are made, so CMS negotiating directly with those manufacturers to create what is the new national offer for the generous model for supplemental rebates and also the criteria. So you could see, though we're on the border here, so Missouri and Kansas, you could see our criteria line up even more in classes where we have drugs here. There is quite a bit of state control, though, because what this model does is it shows you somewhat of a menu. So you'll see the rates and the criteria, but you don't actually have to sign any specific agreement. So you're going to take all this into consideration as you're trying to build your preferred drug list. So the manufacturer negotiations should finalize June 30th of 2026. And then the states, we all have to decide by August 31st of 2026. I think we will definitely sign up for this one because there's almost no risk to signing up for it. The good impact for us, right now, we actually negotiate supplemental rebates as a single state. So we go to each manufacturer and negotiate rebates to lower the net cost of prescription medicine. This would allow CMS to leverage the entire country's Medicaid population to potentially secure better rates and better criteria. We're still going to have some of the same rules of reviewing those rates against our current rates and what we could get outside of the generous model. We're still going to have to operationalize any kind of clinical criteria and coding and making sure the system works. And then we're still going to have to actually execute those individual contracts. So I almost see this one as the best of both worlds. We can go our own route if we want to, but we can also get a better rate potentially if we go through this national negotiation. On the Kansas side, I know that their program does have managed care organizations. In Missouri, we have carved pharmacy completely out of the managed care organizations. So we have one formulary for all of fee-for-service and the managed care patients. It's all through MoHealthNet fee-for-service. But on Kansas, they'll have to figure out how to align all of their managed care criteria, PDL placement, for any offer that they do end up accepting. The next one is the balance model. This is the GLP-1s and obesity. So this is going to be focused on weight loss medications, specifically GLP-1s, and potential lifestyle interventions for those that are overweight and obese. Medicaid timeline, I put 2026. It is, in theory, supposed to go live in May, but May is actually not a standard timeframe for rebate cycles for Medicaid. So I anticipate this. If MoHealthNet in Missouri do join this model, it would actually then be later. It'd probably be July at the earliest. So standardized care is what the benefit would be here. CMS negotiates the guaranteed net pricing, they standardize the coverage criteria, and then the states can choose to adopt it or not. Side note here is that Missouri, for MoHealthNet, we have covered certain GLP-1s for overweight and obesity since January of 2025. And the criteria that CMS negotiated is actually more strict than the criteria that MoHealthNet has. So we would need to evaluate and see what we need to do there. The other issue with this model is if you do join the model, you have to cover all of the overweight and obese therapies. So that means that we do not get to pick and choose anymore what we would prefer. And then I put on here as a note, I don't have control over Medicare, but the Medicare GLP-1 demonstration will launch this summer to bridge the gap until the future full Medicare implementation. The last model I'm going to talk about is cell and gene therapy access model. So the initial focus was on sickle cell disease. Those drugs are $2.2 to $3.1 million per treatment for the drug. They are upwards of 90% effective. The good thing here is state relief. CMS negotiated for us an outcome-based rebate. They negotiated a guarantee rebate, and they also handled the heavy lifting of the data aggregation via our TMSys, which is data that we supply to CMS, our federal partners, every month. A little bit of context on sickle cell disease. We have about 1,000 MoHealthNet participants who have sickle cell disease. We anticipate about 30 treatments in the first 3 years of the model. You can actually go read the article in the paper, I think it was last month, about one of the first treatments in the country. That was one here in Missouri in terms of commercial access. The added benefit here is because it's a value-based agreement that CMS negotiated for us, the manufacturer actually pays for fertility preservation for the participants that undergo this treatment who are covered by MoHealthNet as the primary payer. And then the great thing is uniformity. It ensures Missourians have the same access to the therapy as any other participating state. And this model covers upwards of 80% of all sickle cell patients that have Medicaid in the country. Next steps on that model, of course, utilizing that TMSys data for that national scale outcome tracking. Here's my statistic on 84% of Medicaid sickle cell patients potentially covered. And then the accountability. So we're tracking the medical claims, the pharmacy claims, pre and post infusion to make sure that the patient really does get the clinical benefit. Because when you spend $3 million on a drug, you actually want to make sure it works. So in summary, key takeaway, federal leverage through CMMI is going to allow Missouri to access the new payment models while maintaining state control over the drug selection. And then we'll save the questions till later. So I'm going to stop sharing now. And hopefully I can figure that out.
Thank you, Josh.
Great work.
Wonderful. Thank you so much.
Oh,
Okay, so thank you so much, Josh. So that was good. I didn't know about a lot of those models. So now we're going to hear from Larry Franken, who's going to give us the state programs perspective, an overview of state Medicare programs and their potential impact on communities. Dr. Franken is Director of Medicare Programs at the Kansas Department of Aging and Disability Services. And
Slide next.
let's see which one.
Where did it go?
Is it over here? This one, right?
Oh, yeah, that's it. Just gonna go back to the beginning.
Oh, I see. It's okay.
Thank you. Hello, everybody. I'm going to talk to you a little about Medicare programs and kind of what's going on in that world, especially as it relates to states and the stuff that they're doing to kind of help navigate this really complex issue. Just like you said, my background is in insurance, so I've recently started about 3 months ago with the state of Kansas as their director for Medicare programs. Prior to that, I worked for Blue Cross, and then before that, I worked for Humana. But originally, I worked in public health for a long time as a public health epidemiologist. So I always feel like I'm kind of a data guy, and that's where my heart lies. But insurance is something I think all of us realize is incredibly important. And right now, with our aging population, the Medicare world has gotten a lot more attention as so many more people are aging into that health system. Again, Medicare is real complex. I've done Medicare for 11, 12 years now, and I've never met anybody. And I've had the luxury of like working in a lot of different areas of Medicare, from salespeople to clinicians to the business people, finance, actuaries. I've never met anybody who truly understands the whole thing. Everybody just understands pieces of it. And I still think that's amazing, just considering how important this is. But again, it's so daggone complicated that I've seen even people who've done it for years tell me how much they struggle at times trying to, piece it together. There's the groups that I'm going to talk about a little bit today is the ACL, the Administration for Community Living, who funds the programs, the Medicare programs that I manage with the state of Kansas, CMS, which obviously is the ones who run Medicare and Medicaid for the country, and then a little bit about a new program. Well, it's been around a while, but it's starting to grow in importance, is the PACE organization. And again, it's part of too, and you mentioned the Rural Health Transformation grant that was given $50 billion. Kansas is one of 9 states that is using some of those funds, $22 million this year, to expand the PACE program, which is one of the reasons I took this job. And I'm excited about it, and I'll talk a little about it more at the end of my presentation. Currently, Kansas, obviously, and this is kind of everywhere, there's issues with primary care shortages throughout, not just Kansas, but the whole country, especially in rural areas. And you can see here, Kansas is having quite the struggle. Obviously, 84 of the 125 rural hospitals are operating at a financial loss. 63 Kansas hospitals are at risk of closing. Kansas ranks really low, 41st in the number of physicians per capita. And even nationally, obviously it's an issue. 83 million Americans live in areas that don't have sufficient access to primary care. Health coverage in Kansas, kind of just real high level. There's 1.78 million Kansans covered with private insurance, 343,000 Medicaid, 535,000 Medicare, and that's actually slightly higher. This is older data. It's closer to 550, 560 now. And there's around 27,000 uninsured. In the U.S., there's 70 million Medicare participants. This number is continuing to grow. Everyone's asking, well, how much longer? At least we know for sure through 2030, they're estimating 80 million. At that time, of course, the baby boomers will start dying off here eventually, and that number will kind of plateau and then decrease some. But we know for the next 4 years, for sure, we're going to see an increase in participants. And again, that's about 1 in 5 people are on Medicare in the United States. This is something I guess I want to just touch on. Medicare versus, and you can't see it on there, Medicare versus traditional Medicare versus Medicare Advantage. And there's been a big change in this in my time and working in Medicare, huge change in this. And there's I feel like a lot of controversy around it. And I kind of see why, but it has a huge impact on what's going on with how we're treating our elder population. Medicare Advantage is growing rapidly. And for you guys who don't know, Medicare Advantage is commercial. It's insurance companies, United, Blue Cross, Humana, Cigna, all of them who do managed care health. Traditional Medicare is also called fee for service. And while there are some like MCOs doing managed care, traditionally the bulk of traditional Medicare is just fee for service. Here's a graph showing you the kind of the breakdown. As you can see there, the black line at the top, we're seeing that steady increase in enrollees every year since 2013. The red line is the fee for service or the traditional Medicare, and the blue line, of course, is Medicare Advantage, the commercial side. And you can see how especially in the last few years, we've seen this rapid increase in people enrolling in Medicare Advantage and less in traditional Medicare. And there's a lot of reasons for that. I could spend all day probably just talking about this topic, but a lot of it is related to traditional Medicare has limitations as far as what you can do with it. You've got to pay for your Part D if you don't have it. And if you guys, like I said, go in depth on this, but there's A, B, C, and D. D is drug, A is hospital, B is your PCP. The one reason why you're seeing this increase is because commercial or Medicare Advantage can actually give people more for basically the same money or less money. So that's why you're seeing a lot of enrollment in it. The downside, of course, is with Medicare Advantage, you get limited network. And for some people, that's an issue and a concern. So that's why I think you've seen this big uptake. A lot of it, they're marketing really well, too. I'll give insurance companies credit. They're doing a great job of marketing it. One reason why this isn't bad, and people are like, well, this is bad. I've had a lot of people ask me that, well, this is not good. Well, actually, the government likes the idea of people enrolling in Medicare Advantage. And it's for one really big reason. There's multiple reasons. One really big reason is traditional Medicare fraud's really easy. They have really small administrative teams that go out and track fraud, try to commit fraud against a United or a Humana, and there's a giant team of lawyers all over it, right? They watch it very closely. So that's one reason why the federal government's like, Medicare Advantage isn't all that bad because fraud's a lot more in control. But again, like I said, we're going to see they're expected this to increase from 54% now to about 60% by 2030. It has started to slow off a little bit as people are starting to take a closer look at, do they really want to give up that freedom to kind of go anywhere they want with fee-for-service network? I want to show this to you too, and you can't really see it. I don't know how to get rid of move Josh off of there, but can I slide that over? I don't know if I can do that either.
I think I can help. I'm not sure.
Well, it's probably not that. I guess I mainly want to show the lower two anyway, but
okay. Then
that's okay. I'll just.
Okay.
So the one thing I just wanted to show you, this is Kansas. You can't tell, but this is Kansas. And you can see there, like the rest of the country, it's constantly going up. The number of enrollees in Medicare, overall Medicare. But there's a big gap between, this is where Kansas differs greatly from the rest of the country. We don't have the number of people enrolling in Medicare Advantage. There's a lot of reasons for that. A big one probably is the network that's available in western half of the state that doesn't allow for managed care. So that's a big reason why you're seeing that big gap. Though I think you're going to see it close quite a bit in the next few years. But right now, Kansas is only about 30% Medicare Advantage, with the large portion, obviously, with traditional Medicare. Missouri is actually quite a bit different. Again, you see the black line, the steady increase, but actually has quite a bit more Medicare Advantage than traditional Medicare. And one of the big reasons for that, I think, is the fact that Missouri has one more population, has more kind of dispersed city centers where they can build networks with specialists and with PCPs, which kind of gives them an opportunity to give more insurance companies to offer more options. There's way less options. Actually, there's 22 counties. I think every county in Missouri has Medicare Advantage. There's 22 counties in Kansas that no insurance companies will offer a plan because they can't build a network in that area. So that's a big reason why you're seeing this difference between these two states. And the four programs I'm going to talk to you about with the Commission of Aging. are the Senior Health Insurance Counseling of Kansas. We call it SHIC. Nationally, it's called SHIP. Missouri has a program too. They call theirs the SHIP, which is the Senior Health Insurance Program. Senior Medicare Patrol, which is basically our fraud program. Medicare Improvements, Patients and Providers Act, MIPA, and then PACE, which is our elderly inclusion program that we have. SHIC is basically, I say, it's just a kind of a program where, so out there's a lot of brokers and agents, and I've worked with a lot of brokers and agents, some really good ones. Actually, most of them are really good people and really want to do the right thing. Like any business, there's people probably don't have the best interest in heart for some of the people they're enrolling. So you get lots of concerns about agents who steer people towards programs, basically, so they get bigger reimbursements with the insurance companies. That's always a concern, though I've not really seen that. But again, that's one of the things people are worried about. But a lot of people go to brokers or agents to get their Medicare. So this is basically the government's way of offering those services. You can get them. Basically, we're unbiased, and we're just trying to help you, guide you through this complex system of enrolling in Medicare. And again, it's volunteer based. It's been around for a while, since 1990, though the funding on it's increased a lot lately just because of the aging population and the need for more resources. It's everywhere. Every state has one, even, Puerto Rico, Guam, District of Columbia. A lot of the counselings are one-on-one. Like I said, we actually go out and train people. We partner with all the AAAs, the area agencies on aging throughout the state of Kansas. We train them on how to do, the enrollment process and how to help guide people for the different parts of it. And then they actually will bring in volunteers, which will help train as well. It's very volunteer based. So I'll say this, you don't get the same quality. And this is something I'm working on probably with our program as you would with the brokers, because I think they have more rigor as far as what they have to do to prove that they understand Medicare. But again, it's a free, unbiased service that anybody can access. And we help with everything, even Part D. So it really doesn't matter if you want to be traditional Medicare or Medicare Advantage. We'll help guide you through that process using the 1-800 number or the Medicare site, medicare.gov, to kind of guide you through how to enroll. And again, nationwide, there's quite a few people, and I think this is going to expand too. There's 12,500 people doing it now and 2,200 sites across the country. MIPA is more of a program just focused on kind of helping with resources for those with low income. It helps with rural areas. It helps with Native American tribes. It helps with kind of any population that may struggle with kind of access to education around Medicare and Medicare programming. It was acted in 2008. We do a lot with the Part D with this program. We do a lot of funding to help especially low-income people learn how to enroll. For those who want to stay with traditional Medicare, in that, kind of get enrolled in that and find what's best for them. There's also programming associated with prevention services. So one of the, again, let's say traditional Medicare versus Medicare Advantage. And Medicare Advantage, those insurance companies are really good about telling you when you need your colonoscopy or mammogram. They hammer you. Actually, they may be too aggressive at times on their screenings. And this is something traditional Medicare doesn't do much at all on. So this is a way, especially those with low income and their health literacy isn't as high, to get them that information so they know when to go get their screenings. And again, it's had a lot of success, especially around Medicare savings programs, which have increased significantly since it started. And again, too, also rural health, quite a bit help with pharmacy, addressing pharmacy access for those people in rural areas. Senior Medical Patrol. This is, again, like I said, just a program designed to Medicare beneficiaries to prevent, detect, report healthcare fraud and abuse. It's volunteer based. So we get most of the people doing it. We have to train them, again, on how to detect fraud, how to report fraud, how that whole process works. We also, as part of the grant funding we give to all these agencies, they're expected to do so many presentations every year throughout their communities to make people aware. A lot of people don't even realize they're being taken advantage of or fraudulent activities occurring with them or in their area. So this is something we're definitely, this is where, I guess, traditional Medicare, we're trying to get the word out for those, especially in rural areas who are, I think, a lot of times more susceptible to fraud. So that's probably a big part of what we do with this program. Again, it's $60 billion a year is the annual fraud costs in the United States. I was just at the a conference here this week, and they had Dr. Oz speak from CMS about fraud. He spent a lot of his time talking about the focus on it here in the United States, and he brought up the fact that in Florida, there are more DME or durable medical equipment vendors in that state than there are McDonald's. And there's about 1,000 McDonald's in that state. So they put a freeze. He said government's put a freeze on any new DMEs in the state of Florida until they go in and figure out what's going on. Where's that fraud occurring? And something that really kind of shocked me said in Los Angeles, a third of the entire country's hospice registered vendors, are in the city of Los Angeles, a third for the whole country. So obviously not a third of all the people dying are in Los Angeles, but that's where a third of the hospices are. And as he was saying, a lot of these, they're realizing a lot of the people in this fraud is occurring through foreign agents who come in, set up these fraudulent programs for Medicare, get as much money as they can, then they leave with the money and go back to their countries before we can prosecute them. AI, and Bruce, AI is getting a big part of this too. They talked a lot about how AI is being used as a way to kind of help target when they start seeing some weird stuff going on with claims. And finally, PACE. And again, this is a program. I don't know how many people here are familiar with it. I love it. It was started in the 70s in San Francisco in their Chinatown, North Beach area, when a group of low-income people from kind of Chinese, Filipino, and Italian descent realized they were struggling with how to get health services for people in those areas. So they came up with a way, working with the providers, to offer programming for more in-home type programming and more community-based services. And then throughout especially in the last couple decades since the 90s, that's really grown. And again, Dr. Oz talked about this too, and I was thrilled to see that he was supportive of this program. And like I said, this is part of the Rural Transformation Grant. Kansas is one of 9 states that's starting to expand our program. But what's great about it, why I'm as an insurance guy and a public health guy is excited about it, is basically we set up these provider group systems, and they're told, here's money. The government's like, there's your money. You do whatever it takes to keep that person in the home. So if that person needs help their water bill get paid, they can do that. If they need, they'll even buy them a Netflix subscription if that person's lonely and needs something to do, and that's what they're looking for. Literally anything they need, and they have 24/7 access to healthcare. So in the middle of the night, I have a nurse that works for me, and she used to work for PACE, and she's like, yeah, 2 a.m, I get a call. I have to go to their home and see what I can do. So it's a great program. It's really for low income individuals at this point, but I think there's a lot of opportunity to expand this as time goes on. But it's really, truly, I think what we want to do, all of us, is like we want people to stay in their home as long as possible. And in this program, they kind of get that opportunity. And the risk that the providers take on is if that person does get really sick and has to go to the hospital, they have to pay for it. So it's their interest, that provider, to do everything they can to keep that person out of the hospital if possible. And again, there's been a huge increase in the last couple of years in it. I said it's only 90,000, and for the nation, that's not a huge number. But I think it's going to grow quite a bit in the next few years as more resources get put into it. There's 190 programs operating throughout the U.S. In 34 states. Kansas, we have 3 organizations doing it. Blue Stem, which is this one here in the center, kind of the darker blue. And then we have in Sedgwick down by Wichita, we have Ascension. And then we have Midland over here in the Kansas City, Northeast Kansas area. When we expand by 2030, we only have 22 counties right now. By 2030, this will be in 59 counties with our new expansion. So we're really excited about that. We're going to struggle with the western part, I think, just because there's just going to be hard to get a network set up because there's a whole bunch of stuff they have to have. They have to have a pharmacy. They have to have primary care. They have to have a day center for people to go to. So there's a lot there. Transportation's part of this. So I think we're going to have to struggle a little bit to figure out how to do the western part. But we think for the most part, definitely the eastern half of the state will be covered. Missouri also has 3, I should say. They also have 3 programs. One here in Kansas City, I think it's called KC PACE, one in Springfield, and one in St. Louis. All right, that was kind of my overview. If you do have questions or anything, people, please contact us with Medicare, or if you need help or resources related to helping people with Medicare, we're happy to help. Thank you.
Thank you. That was really informative. I learned a lot. Okay, so our next speaker is Dean Melissa Joy Roberts, who is Dean and Professor at the UMKC School of Nursing and Health Studies, who's going to give us an education and workforce perspective on utilizing the nursing workforce to advance regional health care. So let me pull yours. Let's see. Do one of these look familiar to you?
Where am I? There I am, the green one.
Okay, there we go. And is that the first one?
Yeah,
Okay.
wait a minute.
No?
Nope, that's not the first one.
That's
Let's see if
not-
we can go to,
Uh-oh.
oh, here, try it, wait. There you go.
There we go. All right.
All right.
Hi, everybody. Happy to come today and talk about ways to improve rural healthcare in Missouri. I am a family nurse practitioner who worked for many years in far northwest Missouri as the sole provider at a federally qualified health center in a tiny town of under 300. And because we were in FQHC, we were able to offer a sliding fee scale. I've got some nods there. Yes, that attracts patients, right? So we had several thousand patients. The majority of them were Medicare, Medicaid, or completely uninsured, to the point that it was always a surprise when we had someone who actually had insurance. And I can recall one time, one of our very memorable patients, there were a lot of memorable patients, but she and her daughter had been patients of ours. The daughter was on Medicaid. She was about 9. Her mom was a full-time student with no money, so she only had to pay $5 a visit for her care. And one day, the child's father, the ex-husband, passed away, and the next day, mother and daughter showed up, and she was rather excited because she had money. Because now her daughter would be getting Social Security from her father's passing. And she came running in and she said, well, first she said, guess what? My ex-husband died and he was a skunk. So we said, oh, that's too bad, because the daughter was there. But we didn't think it was that bad. And she said, this means I have money and I am here to pay what I owe. And we said, and she's got money out and she's waving it at us. And we said, but you don't owe any money. You've paid your $5 every time you've come here, even when it meant not buying the pens and notebooks that your daughter needed for school. And she said, but now I have money, so I need to give you some money. And we said, no. She was very enthusiastic about being able to actually pay for her care after having gone so long unable to. She did finish college and got a very good job with her education. But I will never forget that. I will also never forget the patient who came into one of my graduates from our master's program, who became a family nurse practitioner, and in a house in her tiny, tiny rural farming town, opened up a health clinic. And she used to take some of our graduate students for their clinical experiences. And the student called me up very excited one day and said, you'll never guess what I saw. Now, I have pictures, but I did not put them on this because last time I showed them to people, someone fainted. But the first one was what happens when on a windy day, someone decides to move their barbecue grill, but doesn't lower the lid first. So the finger was completely severed. And we had pictures of that. So with that, there was only a certain amount that we could do. And then we had to find a place for this indigent patient who was a full-time farmer, but no insurance, to go for care for the amputation that they had committed to their finger. Then that afternoon, a child came in holding her tummy. She was about 9 or 10. And she came in holding her tummy and said to our graduate, the nurse practitioner, Miss So-and-so, I need you to look at me because I hurt myself. What happened? I was riding my bike, and I went over a bounce, and when it bounced her up, the handlebars came out completely. She fell forward and she had impaled herself on the metal post, and her intestine was exposed for all of us to see. And it had actually pierced the intestine, which is really, really bad. And we said, "Where is your mom?" And she said, "My mom's at work." "Is your dad out in the field?" Dad was a farmer. Yes, he's out in the field. "Well, we've got to call your mom." And she said, "No, don't call my mom. Can't you just fix it?" My mom said that we lost our health insurance. So she told us that we're not to do anything stupid that'll get us hurt. And she was very upset that we had to call her mom. But of course we had to. We had to call in a life flight to fly her to Children's Mercy. They were uninsured. And the fact that a child had to say, "Please don't tell my mom that I have eviscerated myself because we don't have insurance," was a thing that will stay with you forever. So, by the way, the child was taken to Children's Mercy and had a repair, but a lengthy stay in the hospital because of the damage. And I started out with that because this is still the state of care in Missouri, in rural Missouri. Still, for as long as I've been a nurse in Missouri, which is a really long time, there has been a critical workforce shortage for healthcare providers in rural places in Missouri. Adding to that now, the recent shifts in our regulatory standards in Medicaid funding, in funding for programs in rural health that are meant to improve access to rural health. There were, supported by the Department of Health and Human Services, many program projects, program grants that they funded that allowed for the support of new health-related programs to be taken out into rural Missouri, and also to help increase the number of healthcare providers, physicians, nurses, dentists, and psych mental health providers in rural areas, because there is a real, a dramatic need. When I started in the tiny town where I practiced, the two counties, the county where I had my office and the county just to the north where the community medical center, which had about 14 beds, that was the hospital. We had 6 physicians, and they were all 70 or older. And they were there because they had been there since 1950. So of course they stayed. They had grown up in rural areas of Missouri as well. But they were not being replaced. And then ultimately, when this was really noticed, as these folks were passing away, Missouri started some focus on filling the shortages in rural and underserved areas and providing rural care to rural underserved communities. So here's the biggest information that I want you to remember, and that is Missouri has 114 counties, and of those 114 counties, 111 have been identified as healthcare professional shortage areas. So 111 out of our 114. Someone asked me today, well, which 3 counties are not shortage areas? And I said, I bet you can guess, right? St. Louis County, Platte County, Boone County, the larger centers of population. Those are the ones that don't have the shortages. And to be designated as a HPSA, a health professional shortage area, there are shortages either in primary care, pretty much everywhere, rural, dental care, and mental health care. And that continues to this day. There was one dentist in the county where I was practicing, and her name was Dr. Joy, and she had previously been a research chemist and had patented several medications that are still fairly commonly used, but decided she wanted to do something in a rural area because she had grown up in a rural area. So she became a dentist and was seeing patients and was the only one, but she had to support her business and herself, which meant she did have to charge people. And this was problematic in an area where people are underemployed, unemployed, uninsured, underinsured. And eventually she had to close her practice and move to practicing in a federal facility because she couldn't continue to support it. And this was in a place where when it was shortly after I had started seeing patients there, I was doing a well check on a child of about 4, and I asked, do you brush your teeth? Because that's something you want, to teach toddlers. And this child looked at me like I had started speaking French. And I said, your teeth? You brush your teeth with a toothbrush? And the kid's like, what are you talking about? And mother chimed in and said, oh, they'll teach them that in kindergarten. This is why I see all these dental caries in these children, all these kids with silver smiles, right? It was because there were not dentists around and because of the cost for dental care. The obstacles to filling the rural workforce needs. Number one is recent changes in federal funding for health programming, educational grants, and Medicaid. The newly announced caps on federal student loans for graduate students. The professions of medicine, dentistry, pharmacy, and law are not affected by these caps. However, advanced practice nurses, nurse practitioners, registered nurse anesthetists, psych mental health, clinical specialists, and nurse practitioners, that was the cap is applied to them because they're not listed under the professional category. And this means there will be far fewer educated and then therefore far fewer available because it's expensive. Clinical education of all types, that's expensive. Just like PT, OT. These are our clinical professions that are greatly needed in rural areas. Just 2 years ago now, my mom had a huge stroke, and I found her on the floor of her home. My mom is 95, and she lives by herself in a home that she bought not too long ago after my dad died. With her, she lives there with her dogs. She still drives, for better or for worse. She drives a silver Toyota convertible with the black top. So just keep your eyes out. She has not had an accident, but it gives me the creeps. Okay. So I try and drive her places. And I found her, and she had been on the floor for probably 8 or 9 hours. Yeah. And so, that was quite grim. She, had, right-sided, paralysis, and she had just had surgery on her shoulder. So she really was not able to move that, and she couldn't speak, but she could understand what we were saying. And what was miraculous was that we took her to the hospital, and they sent her to neurosurgery, and they were able to evacuate the thrombus. There are a limited number of hospitals that even perform that surgery. They just scoop it right out in a little net. And when we had last seen her, because she got quickly taken to a different hospital for this surgery, and we drove down there, and by the time we got in, they had just brought her out of the surgery, and they brought her to ICU, and they said, you can go in for just we just got her in there. And I walked in with my husband, and she looked at us and said, hi guys, I didn't know you guys would be here. And I was astonished. She was then sent, because she's insured through Medicare, and she lives in Kansas City, Missouri. She was then sent to the Rehabilitation Institute, which is full of OT, PT, psychologists, you name it, the best care ever. I can't sing their praises enough. And when she left there 10 days later, she was in better shape than before she had the stroke. People should be able to have access to that care closer to their home than a 2-hour drive. That's me editorializing. I'll try and stop. Our obstacles include the caps, as well as cuts to federal research and public health initiatives. And with that, particularly the obstacles at the federal level, Missouri has started trying to step in and find other methods of funding. However, Missouri is also facing a $1 billion budget deficit now, and it's a bit of a stretch. They have allotted $3 million a year to help support the education of nurses, to make new nurses and to make new nurse educators, which has been wonderful. And that has been done in the form of grants. And what we want to do is be able to get students who will live in these rural areas and bring them to school to become nurses, and who will go back into their home counties, which of course are underserved, so they can help improve the health access in those counties. To overcome these obstacles, number one, allowing registered nurses and advanced practice registered nurses to practice to the full extent of their education and skills is necessary. Right now, Missouri is one of the last holdouts out of all of the states, maintaining restrictions on the practice of nursing. And when I say restrictions, I mean not letting them practice things that they were educated to do. And we are continuing to try and get that changed. And we have made some small incremental headway. Kansas is ahead of us in that area. We've been working to increase the use of telehealth in rural areas to get access, once again, for our patients, access to specialists, et cetera, as well as digital innovation and using AI to expand healthcare services throughout rural Missouri. That's where we're going to have to go. We have a lot of technology available, so we're going to have to use it, even though face-to-face and with touch and supportive words is the most best care. We have to use any resource possible to get the care out to people in rural Missouri. I had already mentioned the funding sources in Missouri, at least for nursing, and there are similar grants through the state of Missouri to help support the creation of and the education of more licensed practical nurses, as well as physical therapists, occupational therapists, speech therapists, and even people who work as, say, sterile technicians, which is something no one ever thinks about. Some of you might even be wondering, what the heck is that? And that is the person who manages the sterilization procedures in the hospital for surgeries and such. The sheer number of sterile pieces of equipment that are brought into an OR for a single surgery is staggering. It's a big thing. It is something that could really give jobs to a lot of people, but it's generally done in hospitals. And hospitals in all of these rural counties are disappearing. Yeah. So the last thing would be bringing professional nursing education to rural areas via satellite programs, online education, and public school engagement. Those are not new things, but they're things that we have not fully embraced to the full extent that we could and should. And the fullest extent would be taking the education to the rural places, getting into at least the high schools to allow students to get the education and experience, get a start, and then have some sort of arrangement where we can offer the didactic and educational preparation right there, so the student doesn't necessarily have to leave their home site. And students who have just graduated from high school, the first thing they want to do is get the heck out of wherever they're living and get away from their parents. But if they go away, they're less likely to return. And I try to practice some self-restraint here because I'm a talker, as you can guess, a talker and a storyteller. And are we supposed to wait for questions until after? Okay. Okay.
Thank you. Yeah, thank you so much.
That was great. Okay, thank you so much, Joy. And now we'll go to our final speaker before we take some discussion and questions. And so we now have Bob Dees, who's the CEO of Samuel Rogers Health Center, on an FQHC perspective. Very interesting under these new policy changes, policy shifts, disruption, and the return on relationships. So really looking forward to your talk. And then let me see which slides are yours. It looks like these, right? Bottom one. Yeah, perfect. I'll go to the top. All right, floor is yours. Thanks.
Wow, healthcare is complicated. I'm going to talk from a safety net perspective, FQHC, fairly qualified health center. you know what happens to the safety net affects everyone. The rural healthcare. A lot of FQHCs are delivering babies in rural areas. There's one FQHC in Kirksville that's delivering babies in 11 different counties. But I'm just saying, as the rural areas get affected, they're coming to Kansas City, they're going to Columbia, they're going to St. Louis and Springfield, and people are getting care. So that we have to make sure that preventative primary care is taken care of. So federal landscape is constantly being redefined. I mean, I feel like the ground is shifting from underneath me right now. Coverage, workforce, value pressures, we're always being asked to do more with less. System instability, that also gives us an opportunity. So as a fairly qualified health center, I think there's a bigger opportunity for us to keep people out of the hospital, out of the ERs, because for every dollar spent on primary preventative care, we saved the whole system 13. Medicaid is the backbone of the safety net. So it's a core payer for safety net providers. University Health, it's their number one payer. Any coverage changes means access changes. So as people fall off Medicaid, that means they'll have fewer options. I don't know if you knew this, but during COVID, fewer people went to the doctor. And when fewer people went to the doctor, guess what? A few years later, they all ended up in the hospitals. And so as an insurance person, that's where the spend is, right? So, the safety net, FQHCs, they're actually community health infrastructure. So the workforce constraint, we're all trying to fight for the same people. And that means more money. You know what? We train people and then they go off and work for other places. And I feel like we're the training ground for healthcare. Burnout, admin burden. I don't know if you know this, but the average provider spends about 60% of their time in that electronic health record. That's a lot of time. That's a lot of burnout. We have a nurse practitioner residency program at Sam Rogers, and one of our graduates came to work for us. She said, I only want to work 4 days a week because I want some quality of life. And we go, that's great. But she was spending that 5th day documenting, catching up on documents. And so the pipeline and retention, I was shocked, but not shocked. 111 out of 114 counties. Where we are located on the northeast side of Kansas City has a huge provider shortage. So the good news about that is anyone who comes to work for Sam Rogers usually gets their student loans paid. So there are opportunities. Technology. Oh my God, technology is evolving. So that nurse practitioner, we introduced ambient listening. And so she's documenting and getting everything done in that electronic health record just 30% of the time. And so when she walks out of the room, she can sign off, read her notes, sign off on the document, and then the recording goes away. So data is improving care. We're finally seeing in the last 5 years what EHRs can do, right? Because all that data is coming together. When you have that data at your fingertips, I'm a data geek too. When you have data at your fingertips, you can make good decisions. And sometimes other people can use that data. So one thing we did at Sam Rogers is, you know what, we have a great WIC program. 95% of our moms initiate breastfeeding. And our WIC programs, I think the number one program in the state of Missouri. And what we did was, I was just Googling, what does WIC do? So nutrition, they make sure they have a primary care provider, and immunizations. So we put WIC participants in our pre-visit planning. So every time they made a stop at WIC, they would remind them that, hey, when you come in tomorrow, there's a few immunizations you might need. Our immunization rate went up 13% in 1 year. And right now we lead the state of Missouri for FQHCs in immunizations. Data. So all this stuff enables scale, but not replacement, right? AI will not replace humans, but humans with AI will replace humans without AI. You know, that burnout, it will slow down. Quality of life will come back. And I was cornered in our parking lot the other day by some of our nurse practitioners, and they go, "Bob, you can't get rid of this AI." And I thought they were going to beat me up. So luckily, we're not getting rid of AI. I think it's going to get better and better. I think it's going to work for more people in the workforce. Right now, it's geared to providers. MAs, LPNs will start being able to use it. I think community health workers will be able to use it. I really think that it will evolve and be available and make the world a much better place by reducing administrative burden. So as community-based care, we integrate medical, dental, behavioral health. Prevention equals better outcomes, lower cost, and the care is closer to home. And that closer to home thing, you know what, in preparing for this, I just wanted to see it's regional, right? So urban, rural, 24% of rural residents in Kansas and Missouri are on Medicaid. 24% of rural residents. That's 1 in 4 about. Then in the state of Missouri, 41% of people on expanded Medicaid live in a rural area. So keeping signed up for Medicaid is going to take all of us touch point that we have to remind people, is your address up to date? Do you know when your renewal date is? Do you have you received any mail from Medicaid? So we're going to have to help people because they don't necessarily know what's coming. And so we just have to work together as a team. No system can solve this alone. We need aligned partners and then a shift from competition. We're not competitors anymore. We have to be coordinators within each other. So whether they're at the hospital, whether a patient's at the hospital, is your address correct with Medicaid? Do you know your renewal date? Are you getting mail from Medicaid? So coordination is going to count a lot for everything. In closing, I'm going to get us a little closer. The system is changing and it's changing fast, and we don't even know what's coming. So it's scary when the safety net and the state don't know what's coming, but there's an opportunity to shape it intentionally. We can strengthen access, improve outcomes, and ensure long-term sustainability by working together, keeping people out of the ER. I don't know if you've been to an ER lately, but they're full, and they're full with rural people coming in because that's their last place. And people utilizing the ER incorrectly. So we want to make sure that the ER is utilized correctly. But bottom line is we all need to work together. We had a little healthcare forum at Sam Rogers with the mayor and state representatives and community partners because we're all working together. And there was an article that came out of the Beacon, Kansas City today. And so I just want you to, if you have a chance, look up this article. It's about thousands could lose their Medicaid in Kansas City. Health leaders are calling for action. So it's working together, holding someone's hand through the process and just trying to make it easier. So that's what it's all about. So thank you.
So I'm John Spurtis. I work with Stacy and Pat in organizing these as part of the Healthcare Institute for Innovations and Quality. Boy, thank you all so much. What terrific presentations. And I've got to say, a lot more optimistic than I expected. And, I always end up sort of taking too much control. So I have a number of questions, but I first want to give other people a chance to ask questions.
I'm just going to do this while you talk. Or, yeah.
Okay, nobody has to talk. All right.
Sorry.
No, please, James.
No. And of course, I'm always partial to older adults and aging. It seems like it requires an all of society emergency response. And yet, not anywhere, including the massive changes at the federal level, do I see people seemingly taking this seriously, like and really addressing the issues at their core. Would any of the speakers speculate that we're actually at the point of the collapse of any of these systems or massive dying of older people? What are the consequences that are intended?
John. Yeah, because I don't know if they.
So James raised a really sort of omnipresent concern for many of us in the field, which is that, we are just floating along with enormous challenges and threats to the funding of healthcare, despite the progress in getting greater insurance access, more preventative care, et cetera. There have been such abrupt changes very recently that the concern that all of a sudden we're going to have such a loss of insurance and access, such a loss of workforce, failure to expand those who could really provide care in urban or in rural areas, probably much worse in the rural areas. The threats to Medicaid funding and all the threatened hospitals and the rural hospitals that are already on the threat of collapse. We have this little bubble right now for a couple of years where there's this investment in rural funding, but that's going to run out. And so he's sort of challenging us to say, like, when are people going to start taking this seriously? When, are we going to wait for people to die in the streets? I mean, that essentially that's how Medicare got funded, as I recall. It was just literally old people were just dying because they couldn't get access to any care whatsoever. And so he's challenging the four speakers to solve this for us. What's happening? What should we do? Why do you think nobody is in the streets really, calling this cry of concern that several of us are feeling?
I'm going to
Joy?
try to.
Yeah, please.
I was pretty worried too, especially when we first started hearing about the big beautiful bill, and then we started hearing about the cuts to federal funding. And a lot of people that I work with were asking me, because I'm also an attorney, and so they think I know stuff, which is funny. I know a lot more being a nurse than an attorney. But I said, first off, number one, it's not a done deal, cuts or whatever, until all the lawsuits have been determined. So I said, don't panic yet. But what really made me get a little confidence that things can actually, that people can and will stand up and say, no, that's not what we want, we the people, was a situation that happened earlier this spring where federal funding for drug and alcohol addiction and mental health was completely cut, even though it had clearly been stated in the big beautiful bill that money was supposed to continue. And it was announced, the people who had received this funding, and it was, hundreds of millions of dollars, the way they found out that suddenly they had their funding taken away was at 7 p.m. at night. They got emails that popped up, and that said, your grant no longer meets the requirements for funding and has been closed as of I think it was 7 a.m. tomorrow morning. But it happened that all of those recipients, and there were hundreds and hundreds of them, were at a big national conference at that day. And so all of them, as one of my colleagues described to me, because she called me that night, and she said, I got a ping, so I looked at my phone, and I was getting off the elevator with a whole lot of other people just like her, and they all got it. And then she said, I looked at mine, my heart stopped. I looked around, and everybody else had the same look on their face. But because they were together, they immediately converged in a place all together and started a plan. And in about 36 hours, they got their funding back. And I was floored. I was happy, but I was floored. And part of that, though, was because some of the funding was in the hands of private groups that had attorneys. And others, most of them were public, who didn't have money. They might have had attorneys, but not money for, yeah. But seeing them all come together and be able to make this change by, well, threatening legal action, not threatening, taking it, and being loud and being able to contact the right people. By the way, this conference where they were was in DC, and they were able to call. Yeah. So just seeing that did my heart good.
I don't know if this might have a question in the chat. Sean O is asking, what are the likely impacts of MFN drug pricing as manufacturers delay launches abroad? How will this be expected to impact innovation in R&D? Sounds like Josh.
I'm going to guess that's a question for me. Yeah. So, we saw this with the AMP cap removal. So for those of you that really get nerdy about drug pricing, about a year and a half, 2 years ago, Congress passed a bill that removed the maximum rebate cap on drugs and Medicaid. And they thought this would be a cost savings because some drugs had inflated their prices so rapidly over the last decade or more that the rebate that they owed Medicaid was actually more than the price that they were selling the drug for. You can see these in penny priced drugs in the 340B program. So CMS said, yeah, this is going to be great. You're going to save so much money because they're going to be paying you more in rebate than what you pay for the drug. You're going to turn a profit. This will be fantastic. Of course, then the manufacturer said, well, why would I give money to Medicaid like that? It will just cost us money. This is insane. So, of course, you saw things like Flovent go off the market. You saw insulin prices drop to $25 a month. That was not due to any other price caps. That was strictly due to the Medicaid funding piece of it. As much as those manufacturers might say that it was some other piece of goodwill, it was not. So, yeah, I mean, if there's maximum fair price or, the MFN pricing, the most favored nation pricing, it may result in delayed launches abroad. It may result in drugs being removed from the market abroad as well. You may see what we've seen already in the Medicaid space is very, very high launch prices as well. That way they don't have to worry about the inflation. They can just go automatically to the price they're going to want to be at in 10 years. So that's a long way to say it's hard to predict, but these are very intelligent companies. And when we saw the generous model announced, we did not see a single drug company drop their stock price at all. So I think that this is not going to be a material impact to the bottom line of the manufacturer, but how that approaches the different international availability of drugs, that's a little bit more difficult for me to predict. I would see some increases in prices abroad. And yes, some drug manufacturers will likely not launch their drug internationally if they think that's going to devalue how much money they can make off the American market.
So I have a question, and I'm just so glad Larry walked back in. Josh, for you, the generous program sounds amazing. Listening about CHIP and MIPA and all that sound amazing. But I'm also struck by the increasing administrative burden on screening people, qualifying people. For all of this talk about getting rid of waste, fraud, and abuse, the first term is waste. And the administrative expenses that it's going to require to every couple months check that somebody's worked enough hours to be able to, I mean, it feels to somebody like me like it's almost, weeding or restriction of services by administrative burden, but somebody has to be on the other end administering all that stuff and verifying it, double checking all of this. And so my question is, it sounded so encouraging to hear about some of the pharmacy programs that we have here in Missouri to help support through Generous and through the Balance program, some of the social services and in-home services that you're trying to create and offer. But, it's for people who can demonstrate a need, and yet how much is it going to take for you to be able to validate or verify that? Or are they going to cut your funding federally because you're part of the waste, fraud, and abuse because you haven't spent the administrative waste to prove that you're not wasting money on the people who you're providing services to? And so if you guys could easily answer that for me, I'd be really happy.
I don't know if I easily answer that question for sure, but it's a lot of pieces. We want to make sure that the dollars that we are spending are going to those that are within the safety net and should be within the safety net. So that means we definitely want to make sure that the participant's eligible for Medicaid. I don't think anybody here wants to spend money on those that should not be eligible for that bucket, because that takes away for those that are eligible and that we do intend those funds for. So we're going to continue to look at the continuous edge or the community engagement requirements every 6 months. We are investing heavily in technology to try and streamline that as much as possible. We're also looking at medical frailty and what that definition is. There's still a lot of confusion at the national level. The guidance from CMS on community engagement has not come out yet. We're expecting that to come out this summer, and then we'll be able to implement that in the system. But we really are looking more towards technology to try and remove as much as possible from the need for those that we know are meeting continuous or community engagement requirements. We don't want them to fill out a bunch of paperwork telling us what we already should know through the electronic databases.
Yeah, I guess, I was unaware of how big the problem. Medicaid is not the preferred coverage for a lot of patients in getting access to care. It can be hard to find providers, et cetera, because of its reimbursement rates. And it isn't, nobody wants people who, have a lot of resources to be living off the government dole. And I just don't know how big a problem that is. But I do know the expense and the challenge and risk of being able to document. I had to get my real ID, find my social security card. That was not a simple task, and so I'm just wondering how we can allow the dollars invested in these programs to be spent on the medicines that our patients need, or access to primary care that our patients need. And as I recall, there were a number of states had invested in these work requirement programs, and it did not save much money. Now, I could be wrong. You guys are the experts, which is why I'm asking you. But and again, nobody's going to listen to us here. But to me, the challenge is that, as we think as a community, what is it that we could do, and how could we frame what resources are available to most impact the health and access to care of our community? What should we be doing? And, if you think, and I find it reassuring that the administrative burden is not going to be so great, that's reassuring. I don't know what you think, Larry, if the validation and the screening and the delays in processing all of that is going to be, are the benefits of not expending the resources of people who don't need it outweighed by the denial of care or the delays in care. As a cardiologist, you delay care getting treatment for a heart attack or a heart failure, it's a big problem, and it costs us a whole lot more money. And now there's no coverage, and you're not reimbursed at all. And so I'm just wondering, from a SILE perspective, what you guys think about all of these administrative requirements.
As an inch, I'll say this, and one thing that as an epidemiologist too, as somebody who's like studies data and people getting them health. Josh, can you hear me okay, Josh?
Barely
Josh,
can hear you. I'm leaning in. I'm turning up my volume as much as I can.
I think that the thing that kind of is amazing, and having done this, I saw this at Humana and I saw this at Blue Cross. We know people who have issues. We know people who are going to fall. We know the data and analytics. There's some amazing people in the data they can pull. Heck, I was even at a meeting once when at Humana when the senior analyst got up and said, I know when everyone in this room is going to die within 3 months with a 95% probability of accuracy. That's how good some of this data is. The problem is, like, people who's going to have heart disease, hypertension, it's getting them in, right? We can identify them, but a lot of it is just pulling those people in to get services. That's, to me, is the really difficult part of all this. And the administrative costs and stuff, I still think is we're not where we need to be as far as like how to tie what we know to getting that out to the public, to get them informed of what health issues they have and how they, again, a lot of people just health is not a priority for a lot of people, which is sad. And you work with seniors especially, you'll see a lot of them just like, I'm not going to live forever. So why do I want to go through all that agony or pain or whatever to have that done? So anyway, that was my 2 cents on just one of the struggles that we have as far as like how to use the data we do have and the information we do have.
And
sorry.
I don't want to pretend that there won't be anybody that gets incorrectly taken off or due to some kind of paperwork issue. I'm not going to say that there won't be a single person. There likely will be those that we struggle a little bit to get through the system because we can't prove their work requirements or their school or their volunteer. Those things will come up. What our focus is to make sure the vast majority are done through the electronic process as we've implemented this. And to your point, several states have tried to implement work requirements for community engagement. We are taking the lessons learned there. CMS is as well. We're also not the first state that's going to implement work requirements. You'll see, and I'm sorry, I keep on going back and forth with work requirements and community engagement. That's because the General Assembly keeps on going back and forth, so I have to speak the lingo of those that I'm talking to. But Nebraska is going live. I believe they're going live in May. So we'll get what they're doing in May. We'll get what's going on in several other states throughout the summer, and then we'll be implementing at the end of December.
And just to be clear, I wasn't really thinking about getting wrong a few people who shouldn't be covered. I was worried about people who clearly should be covered, and there's just a lot of delays in time in doing it. And I'm curious. I mean, what I really want, my last question, I'm already over time here, to be is that I think that Kansas, we're investing in the Healthcare Institute for Innovations and Quality because we think there's a very unique opportunity to bring multiple stakeholders in healthcare together. This forum is a great example, and I wish it was going on for another hour so we could solve all of the world's problems in one afternoon. But in reality, we do have the opportunity to think about novel partnerships, novel strategies, ways that we should be thinking about handling it. I mean, I am very worried, in a few years when, I don't know what Missouri is going to do with a constitutional amendment supporting Medicaid and a loss of federal support for that program. It's what everybody feared about with Medicaid expansion. And now we're in a real jam. So in 5 years, if we take James's approach about what's the future state, what should we be doing today as a broad multi-stakeholder community to think about innovative ways, Larry, to communicate to people the advantages of preventative care rather than showing up with a stroke? How do we think about ways of increasing access, minimizing barriers, and making doing the right thing easy when we're living in a world with limited resources to begin with, mistrust, miscommunication to start with, and a future that looks far less financially viable than it does today? And so maybe in like 2 minutes or less, any ideas that our speakers could give us or others from the audience, and then I'm going to walk away so I don't ask any more questions about what you think, if you could really try and do one big initiative regionally to improve and address some of these issues, what would it be? We'll start.
I think it's all about data, coordination, cooperation, trying to figure out how to work together. People don't know it's coming. The sky is going to fall. I was trying to be an optimist, but I'm supposed to give hope out there, right? So I hope that we can all come together, figure stuff out, know good preventative care, communicate with our families. You know, if you have a family member that you don't like to speak with, you know what? You have the same genes. And so I found out two of my brothers had heart trouble, and I just found out I had heart trouble, and it's like, I didn't know. I just thought they were a mess. And so having communication, talking to other people, sharing information, data, and getting the right people to come in at the right time, which is way harder than it is to say. So.
Josh, you want to?
Yeah, so I'll say that what we're focused on is developing the right payment methodologies to incentivize the outcomes that we all want to see. And part of that's making sure that we invest in primary care because healthier patients are cheaper for a whole lot longer. And so reducing hospitalizations, reducing avoidable ER visits, those kinds of things are really important. I continue to hear the sky is falling, and I've been in Medicaid now for a little over 14 years. So I have heard it for 14 years that the sky is falling in Medicaid because of budget crunches. I can tell you that times are changing, and Medicaid will look a little bit different in 5 years, but there will still be a Medicaid program. We will still have a pharmacy program. We will still take care of those that are our most vulnerable citizens. We will continue to be a safety net. So I continue to be optimistic about the future. I don't think the sky is falling.
Josh, that's a wonderful way to wrap up today. Thank you. That's heartening. And I know we can't, John gave us 2 minutes to solve the problems of the world. Presenters, we are so grateful for you. Thank you all for saying yes. Thank you, Bob and Dean Roberts and Larry and Josh. You were wonderful. Thank you, thank you, thank you. Those online, thank you, and we'll see you in May.